Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity for this debate. And this is a very controversial and interesting debate that we are having today on the role of first-line agents in patients who can't afford immunotherapy. So today, I'll be debating for Sunitinib as the preferred first-line option in patients with the RCC who cannot afford or are unfit for immunotherapy. So we know that how it was discussed in the session before this, that there is a paradigm shift in the treatment of advanced RCC with the advent of immune checkpoint inhibitors, and the whole treatment scenario has changed completely in the past 2 years. And now the treatment of choice in an ideal world scenario is a combination of immunotherapy, that is immune checkpoint inhibitors, with either a TKI or another IO, that is ipilimumab, depending on the risk stratification of the patient. And this is considered amongst all guidelines and recommendations the standard of care. However, we all know that the ideal scenario is not what happens in reality, not just in our country, but many other low and middle income countries around the world. And today's debate is going to focus on what is the option or the best alternative in the real world setting if we have no access to immunotherapy. There are two aspects to not being able to receive immunotherapy. One is if the patient is unfit due to any autoimmune disease where we suspect that the addition of immunotherapy might lead to significant complications. And the other and the more common what we encounter in our day-to-day practice is lack of access, mostly because of financial affordability for these immune checkpoint inhibitors, which is a huge burden on the patient. And recently, a month back, this was an editorial published in the Annals of Oncology, which discussed about improving access to immunotherapy in lower middle income countries. And all of us in our day-to-day practice, we realize the challenges with the use of immunotherapy. And there are multiple efforts, including that at our center, to improve access by different scheduling, dosing. So this is a real challenge, and RCC is one disease where immunotherapy has led to a significant improvement in survival outcomes, both progression-free and overall survival. So moving on, in a setting where we don't have the ideal, what is the best option? Dr. Chandrakant debated for cabozantinib. I will be debating for sunitinib in the first-line setting. And starting off, sunitinib is an anti-VEGF inhibitor which predominantly inhibits the VEGFR2 and PDGFR. The pivotal trial that established sunitinib as a standard of care in another era where there were only cytokine therapies and no TKIs was published in 2007 by Motzer and NEJM. And these were the preliminary phase 2 trials which evaluated sunitinib in various settings, that is in those who progressed on the interleukin or interferon and those who were treatment naive. And this is the pivotal trial that established sunitinib as the standard of care at that time, where it showed a significant improvement in the progression-free survival over interferon alpha with a significant, around a 68% reduction in the risk of death. And also improved the overall survival. There was a significant improvement in the response rate, which was more than 5 times that of interferon, and significant improvement in quality of life. We know that interferon caused a lot of flu-like symptoms, myalgia, body pain. Patients would have quite a poor quality of life. And even though sunitinib, as we know now, has its own side effects and impact on quality of life, it fared better than interferon alpha. And that is how it became the standard of care at that time. This is a subgroup analysis of the study which showed improvement in all subgroups, irrespective of age, gender, and other parameters which were used for risk stratification in the MSKCC risk stratification criteria, that is the calcium, hemoglobin, time since diagnosis, and LDH. And these are some of these sunitinib trials that have come after the pivotal trial, including trials which have compared other TKIs such as pazopanib with sunitinib to look for non-inferiority. And here we can see that sunitinib has definitely had a better outcome as compared to interferon alpha, and was then one of the standard of care. Because sunitinib was a standard of care, it has been in the current era used as a reference arm or the standard arm in multiple trials evaluating newer therapies, including the trial which evaluated cabozantinib in the first-line setting. And these are the new trials which evaluated the combination of immunotherapy with TKI or IO. And you can see that if you look at the progression-free survival here, that it ranged between 5 months to 11 months and was an average of 8 to 9 months with Sunitinib, and an overall survival from 20 to 35 months. And these are the dose interruptions and dose reductions. What I wanted to basically highlight here is, since it was discussed about the Cabozantinib trial and the role of Cabozantinib in the first line setting instead of Sunitinib, this study was a phase 2 study, and here the PFS of the patients who received Sunitinib was unusually low, and I will discuss this in the subsequent discussion. And just as a reference, all these studies use Sunitinib as a standard of care when comparing new drugs. So we know that Sunitinib set a benchmark for treatment of RCC in the first line setting prior to the advent of immunotherapy. So again, this is a slide which shows various trials which use Sunitinib as a reference. Another point in favor of Sunitinib is that it's an extensively studied drug. There are multiple trials, not just the ones which establish it as standard of care, but the ones which use it as a comparator, as a standard arm. And there are also studies which specifically looked at tolerance and patient preference and quality of life in Sunitinib. And we have good experience with randomized data on various ways to the tolerance and the quality of life of Sunitinib. One trial important that showed us the issues with Sunitinib was PICES, which showed patient preferences when they alternated between Sunitinib and Pazopanib. Having said this I just put to highlight the fact that all of us have had experience with this drug. We are well versed with the side effects and how it impacts quality of life, and most medical oncologists will be able to tackle the toxicities of Sunitinib in this setting. So this is the PICES study and the preference of patients. Other than just the randomized trials which were conducted mostly in the Western world, there are multiple studies in various countries, including low-income and middle-income countries, which showed the benefit of Sunitinib. And also one of the larger real-world studies that were there, it showed an expanded access study in 4,000 patients, and there was again a response rate and a median PFS which was 9.4, and which was comparable to what was seen in well-controlled clinical trials. So what do the guidelines say? And it has been discussed by Dr. Chandrakant as well as how the guidelines prefer Cabozantinib. I would like to just show a different viewpoint about how the guidelines prefer Sunitinib as an alternative when you can't give the ideal TKI-IO combinations. And just let's look at the guidelines, how they were, or what happened to the guidelines when there were no immune checkpoint inhibitors, that is the pre-immune checkpoint inhibitor era. And these were the ESMO 2016 guidelines, which, if you can see the red arrows here, show Sunitinib is the preferred option, not just for the good and intermediate risk, it is also one of the options for the poor risk and for the non-clear cell histology, considering at that time there were far less options than there are today. Also, when we look at the ESMO guidelines, we look at two things. One is the level of evidence that they have given, and it is 1A, which is this highest level of evidence, especially for the good and intermediate risk. 1 stands for studies which are well conducted, randomized, very little bias or chances of bias in the study design. And A is the basically the efficacy, that there is good efficacy, evidence for efficacy, and there is a clinical benefit, and Sunitinib met all these criteria. Hence, it was a 1A recommendation for good and intermediate risk and a 2B recommendation for poor risk. Now, moving on to as the treatment evolved and as immunotherapy started coming into the picture, if you look at the 2019 update of the 2016 guidelines, Sunitinib still has the same recommendation for good risk patients. This is before guidelines were published before Pembro-Axi and Cabo-Nivo combinations or other TKI-IO combinations were out. And here, before that era, that Sunitinib still held the same position for good risk. And this goes to show that if you have a good risk patient who has clear cell RCC in the first line setting, no access to immunotherapy, Sunitinib might be the best alternative that you can offer. Cabozantinib does not mention for good risk. It has a category 2A recommendation for intermediate risk with a magnitude of clinical benefit score of only 3. The magnitude of clinical benefit score is a scoring done by various experts all over Europe who are part of the ESMO, and they grade based on a particular scale on the benefit of the study, the the statistical design, how much is the progression, whether it's a study which looks at non-curative, curative therapy, whether it shows an improvement in overall survival or progression-free survival. If you have a score of 4 or 5, that is supposed to indicate a significant clinical benefit. Anything below that is not sufficient. And here, this MCBS scale ranges from 1 to 5, and cabozantinib in both the intermediate and the poor risk has a level 2 recommendation with a magnitude of clinical benefit of 3, which is not the best category of evidence to support its use in the first line setting.
Ma'am, last 2 minutes to conclude.
Yeah, so I'll conclude. So again, this is already what I discussed. These are the NCCN guidelines, and like I said, it is a recommendation for a preferred regimen for poor and intermediate risk, as Dr. Chandrakant mentioned, but it is not a category 1 recommendation, just to point out. This is the latest update of the ESMO guidelines, and if you look, cabozantinib has dropped down in the intermediate and the poor risk again to this the last alternative, and sunitinib retains its status here as well as an alternative in those who can't afford these TKI-IO or IO-IO combinations. And this is where this B stands for where treatment is not available or contraindicated, and this is what happens in our setting where a lot of times patients can't access it. So sunitinib retains its status as an alternative drug where either the patient cannot afford immunotherapy or it's not fit, whereas we all know in an ideal world scenario we would still go for combination therapy. So what was the evidence for cabozantinib in the first line setting? I'll briefly discuss the CABOSUN study. It was compared to sunitinib 50 mg 4 weeks on, 2 weeks on, off, and cabozantinib a 60 mg dose with the primary endpoint of progression-free survival. And it was powered only for progression-free survival. Secondary endpoints for OS, response rates, and safety. And these are the baseline characteristics, and this was the survival curve, which Dr. Chandrakant pointed out that progression-free survival was better than sunitinib. This is the toxicity profile. I just highlighted a few things to see AST, ALT, hypertension, and plantar palmoerythrodysesthesia were higher with cabozantinib, but grade 3 or higher events didn't make a significant difference as compared to sunitinib for LFTs as well as the hand-foot syndrome. It was only the hypertension that was significantly, this was higher than sunitinib. But the study again didn't look for significance because these were not powered, and it was only a descriptive data that was given. So based on this phase 2 study, is this enough, or is this enough evidence to make cabozantinib the preferred regimen in a setting where we can't afford IO with TKI or other IO combinations? Is the issue. The issues were with cabozan study was it is a phase 2 small study. One thing what they said was that the reason for the poor PS in the control arm, that is the sunitinib arm, was probably because of poor risk and intermediate risk patients and patients with higher bone mets without prior nephrectomy. But if you look at the study very closely, 81% had intermediate risk disease and only 19% were poor risk. So whether that was a real reason for having a poor outcome in the sunitinib arm, and this is one of the studies which shows a PFS which was a little out of the way. So whether this study can be considered as a study to as strong evidence to advocate for cabozantinib. Toxicities and dose reductions higher with cabozantinib, but again the study was not powered to assess the difference. And one important factor that I want to point out is that in the sunitinib arm, a large number of patients, around 18 patients, which were around 20% of the sunitinib group out of 78, did not have images for assessment in tumors for the tumor response assessment, and only 6 patients, that is around less than 10% of the cabozantinib had missing data. And again, that means there has been some issues with assessing objective response and the progression-free survival in this small study. So also in this era where all our TKI plus IO and IO-IO combinations are showing improvement in overall survival, a non-significant small numerical increase in OS, is it enough for us to choose this above all other agents? This is the same slide which shows around 8% missing data for cabozantinib, but 23% for sunitinib, which means this is a flaw in the study because the endpoint of the study was progression-free survival. So I want to summarize quickly why I would advocate for sunitinib as my choice if there is no access or if the patient cannot receive immune checkpoint inhibitor combination for any reason. One would be the experience and the robust evidence and the large number of patient data that we have with this drug. It was the previous standard of care, so it has proven efficacy. And also the issues with choosing cabozantinib is the evidence for cabozantinib is not as strong The evidence in the first line with nivolumab is very good, but as a single agent, it's based on a phase 2 study. And in the second line, of course, we know that is a good option. Recommending it for intermediate and poor risk patients, it could be considered, but it should not be considered as a blanket treatment for all patients. Maybe using it in favorable risk patients might be an overkill. Probably a larger phase 3 study might demonstrate a better benefit, and then we could use this as an evidence. And also, if we use cabozantinib as a first line, we are cutting down an option for subsequent lines of therapy. Select indications, we may consider non-clear cell pathway definite benefit and in the second line setting. So with this, I would like to conclude and hand over back to the organizers. Thank you.
Thank you, Dr. Nandini. And I think it's an excellent presentation, both of you, and put forward your thoughts on using cabo as a first line versus sunitinib as a first line. Now we have 1 minute each for a rebuttal. Dr. Chandra?
So yes, sir, I agree, sir. It was a wonderful argument from Dr. Nandini, very valid. Cabozan trial was not, that credible. I agree, but if you look into the guidelines, the guidelines have given the credit for the trial and the data. And if a patient is not affording IO, especially intermediate and poor risk, then the TKI of choice is cabozantinib. And it has stood its test of time, and it has been showing its efficacy even in the non-clear cell variety, as I showed. So I agree, the long-term data, the quality of life data, the real-world evidence, everything is with sunitinib. But cabozantinib is a new kid in the block, and we are seeing its efficacy. Even in the subsequent line, if you use in post-sunitinib progression, it is showing excellent efficacy. So, and the response rates are almost triple than what sunitinib is. And it has got wide range of, pathway inhibition. So by keeping all these in mind, in congruence with the existing guidelines, cabozantinib is still the preferred drug, in the intermediate and poor risk setting. And I agree, in the good risk setting, we can use sunitinib in the good risk patients. But the good risk patients are just 15% or 10% in the real world scenario. So in majority of patients, you end up using cabozantinib, and the cost is almost competitive with sunitinib. So there is no challenge at all. So with this, I would again say, in congruence with guidelines, I would prefer cabozantinib based on whatever data we have. Thank you.
Thank you. Nandini, one minute for you as well.
So based on whatever data we have and the debate that sunitinib may not be the ideal drug for in the poor and intermediate risk, it is difficult to say that because we have no head-to-head comparison. A lot of the data, what even sunitinib in comparison with pazopanib only looked at tolerability and non-inferiority. No one really saw that whether head-to-head TKI is in poor risk, which was the best. So in absence of evidence or with limited evidence, I wouldn't be very strongly recommending a drug that has a limited evidence. It could be considered in certain subgroups, and we could tailor it to certain subgroups, but saying that it is the best option in case we don't have the ideal case treatment, I think I would not make that statement. And also cost-wise, yes, with generics now, it has become equitable. Both sunitinib and cabozantinib are almost the same, so that is not an issue. But in terms of outcomes, I think if I have with the confidence of the data that we have with sunitinib and the experience, I would still recommend sunitinib because it was the prior standard of care. And I think if we can't afford the newer standard of care, we could stick to what we have used before until we have very robust evidence. In case of non-clear cell RCCs, I would still agree with Dr. Chandrakant that there is a definite biological rationale for using cabozantinib with the MET pathway. And there has been phase 2 data where various MET inhibitors have been compared, savolitinib, cabozantinib with crizotinib and sunitinib, and cabozantinib has definitely shown evidence. So there is a segment of patients where we could consider this, but I would not consider it as a blanket for all patients. Thank you.